If you look at a medical map of eastern North Carolina, you'll immediately spot a glaring hole. Across this specific region, 22 entire counties have absolutely zero practicing psychiatrists. The obvious reaction is that we need to build more clinics and hire more doctors. But pouring new resources into an area does little for a patient if those new doctors operate in total isolation from one another. Hospitals, police departments, and community clinics across these counties often function as separate silos, with no shared visibility into a single patient's history or needs. Vulnerable individuals slip into the silent gaps between these institutions, the specific points where one organization's responsibility ends and the next hasn't yet begun. This diagram maps the exact life cycle of a local crisis. 5 distinct institutions typically interact with someone in distress: law enforcement, hospitals, courts, managed care organizations, and community providers. A person stops taking their medication and begins to decline. Friends and family watch it happen, but they can't get clinical help. The situation escalates until there is no one left to call but 911, and the police are forced to intervene. Law enforcement brings them to an emergency room. The hospital stabilizes them on a 72-hour hold and discharges them with a follow-up appointment. But that appointment is weeks away, at a clinic 45 minutes across town, with no bus route to get there. The patient falls straight into the empty space between the hospital and the provider. Without that follow-up care, the deterioration starts all over again. 3 months pass and an arrest happens, trespassing or disorderly conduct. Now there's a record, and the person is standing in front of a judge. In this scenario, every professional did their job. The officer kept the peace, the hospital stabilized the acute crisis, and the judge offered treatment. Yet, the collective outcome for the patient is a total failure. Because these systems don't talk, the patient is passed along to the next crisis. County jails become default psychiatric wards, and local governments spend $60,000 per person every year on a cycle that resolves nothing. Many barriers to staying in treatment are practical. A missed appointment often comes down to a missing ride, a work shift someone couldn't afford to skip, or a spotty internet connection that ruins a telehealth visit. But for many individuals with severe mental illness, the barrier is biological. It's a neurological condition called anosognosia. Physical changes in the brain actually prevent the person from recognizing that they have a disorder. If a person's own neurology blocks them from seeing that they are sick, waiting for them to voluntarily seek out a clinic is a strategy designed to fail. We often mistake this for stubbornness, assuming a patient is making a conscious choice to refuse care. In reality, their brain is actively hiding its own deterioration from them. Treating a biological inability to perceive illness as simple non-compliance guarantees that a patient will stay trapped in the crisis loop. When voluntary care repeatedly fails, the legal system has one specific tool left: assisted outpatient treatment, or AOT. It's a civil court order requiring someone to follow a community-based treatment plan. A court order cannot conjure resources out of thin air. If a judge mandates care and the local clinic has a 4-month waitlist and no transportation support, that order is just a piece of paper with consequences attached. Linked Pathways builds active referral pathways between courts, clinics, and community assets like ride programs and churches. They engineer a warm handoff. When someone is discharged or ordered into treatment, they are handed directly into a service that is expecting them. A judicial mandate is only as effective as the physical infrastructure behind it. Logical coordination is what turns a court order from a legal hurdle into a genuine bridge back to autonomy. This chart illustrates the outcomes of coordinated care models. When these localized networks are activated, psychiatric crisis hospitalizations drop by 77%. We also see an 83% reduction in arrests and county jail days for individuals in the program. The annual cost of someone cycling through crisis intervention is well over $60,000. Coordinated care contracts that cost to roughly $12,000 per person. The data identifies a simple, low-tech intervention driving these results: consistent human follow-up. Checking in on a Tuesday to see if a ride is missing often prevents the crisis on Friday. Keeping an individual connected to their neighbors and their community is the most effective medical intervention we possess. To build a system that lasts, Linked Pathways uses the starfish model. Most organizations build a centralized network where everything relies on them. A starfish has no head. If you remove a piece, the decentralized web stays completely intact. The strategy here is to introduce partners directly to one another and then hand ownership over to the community, ensuring the network survives long after any single agency leaves. In this model, pastors taking late-night calls and volunteer drivers provide the load-bearing infrastructure that keeps a person from falling back into the cycle. When traditional resources are scarce, a coordinated community network becomes the ultimate lifeline. Connection is the only scalable cure for scarcity.